Good morning, good afternoon, and welcome to the webinar. I'm Dr. David Nace, Chief Medical Officer at Innovaccer, and I'm so pleased to welcome all of you to this webinar, Building the Future of Managed Medicaid. And what is the role of the health cloud? So we'll talk about this. So I'm very pleased today to welcome our guest, Alicia Fehrenbacher. Alicia is the Chief Executive Officer of Elevate Health and President and Vice Chair of the One Pierce Community Resilience Fund. Alicia, welcome.
Thank you very much. I'm happy to be here today.
And great to have you. This issue of Medicaid is such an important issue, particularly during this pandemic and going forward. So really excited to hear the viewpoint of where this is all going. So let's start off and say, Medicaid has had an interesting history. We'll all remember in the heels of the Great Depression, middle of it, SSI was enacted. And that was really the beginning of giving states money to help families, particularly women and children as part of that, but also age 65 and older. And then in 1965, due to a lot of work by Lyndon Johnson, amendments were made which created Medicaid and Medicare. And that was the beginning of this history. 1982, we saw the Arizona Healthcare Cost Containment System, which was the first statewide managed Medicaid system. And that began this movement for managing care, bringing managed care to Medicaid. And then over the years subsequently, we saw a lot of movement to expanding Medicaid, the Mental Health Parity Act in 1996, and then with the ACA Act, expansion at the state level, and this continues to evolve. Particularly this concept of home and community-based care in the provision of Medicaid. So I think it's very interesting to start thinking about where is Medicaid today? So Alicia, we've seen a lot of changes. Where is Medicaid today?
I think that we as a community-based agency have been really at the forefront of working with Medicaid managed care organizations, the state agencies, and our health providers, both in the clinical space, but also the providers that are serving the population in the community space. And it seems to be the need is rising. There is disconnected care. And there's a need for greater communication, transparency, and connected data. And I think with the growth and the need in that, the disconnect between clinical care and the community-based care and the social determinants has been, I think, a driver of rising cost and poor quality in the system. And so that is I think that is an area that we have been really focused on and really want to make improvements in as we go forward. And I think that that can really help support the improvements inside the Medicaid landscape going forward.
Yeah, it is amazing. We've seen such an expansion over the years, and we've had a lot of managed Medicaid organizations come that try to manage these costs. But it seems like the states are really struggling with the financial implication. I mean, the percent of the U.S. healthcare expenditure overall is just becoming bigger and bigger. And, what do you think the solution to this will be?
I think the time that I've spent in this space, which has been, a couple decades now, it has been, it seems like it's the silo. And I think it's this component of it's all basically can be fixed inside the clinical space. And we're seeing more and more that is actually not the case. We really need to have interventions, and we need to have supports inside the community space, inside the social determinants of health component. So it is the patient or the client, it doesn't all just sit when they go inside the practice or inside the health system or inside the clinic. There is also interventions and supports that are needed when they're at home or in their environment. And that is, I think, the biggest driver, and having a vehicle and having data to inform the elements of care delivery outside the space and then connecting it into the clinical space is really where we're going to see the biggest improvements not only in the health of the population, but also in the cost drivers of this population that we're really trying to serve and we're trying to improve the health of.
So it is interesting, even on the clinical side, and I've been doing, a lot of this managed care in the clinical side for a long time. There's all this disconnection between data sources and trying to get different entities, like when someone leaves the hospital to get adequate follow-up, ER use is overused, finding a good skilled nursing facility, and then thinking about the social determinants of health and the community. They have pockets of silos and are probably less coordinated historically than the clinical side. How do you bring this all together? I think that's the piece we need to talk about. And we've seen a lot of movement by CMS to think about, how do we think about value-based care? We've seen positive impact of expanding Medicaid, but the cost is driving people, to really consider, how do we think about value-based care and value-based payments? Do you think there's a role here for value-based care, like changing the contract to bring in?
Absolutely. I think that you really have captured something that's important. I think we have our agency at Elevate Health. We really focused with our state waiver, which is the 1115 waiver. We started that a couple of years ago and started that in our community to say, how do we actually look outside of just the clinical care delivery system, and we look at the care, clinical and community-based care. So we started building out a care continuum network, which looked at preconception to end of life, prevention, mid to rising to high risk patient population. And we said, what are the needs that are needed by this population when they're not inside the clinical setting? And how do we actually bring the resources together and have that communication between the clinical provider and the community-based resource so we can really look at whole person care? And so that was a key component of this model of really getting towards this value-based payments, value-based contracting, value-based care, and really focused on better quality, better value, better provider experience, better patient experience. It's the heart of what you need to do is really looking at that clinical and community component and the collaboration of the two coming together. But without having a resource to do that can be communicated effectively, that is where I think the gap is in value-based contracting. You have a payer, an MCO, a managed care organization, you have a health system, you have a provider, they may be on EHRs, electronic health records, and they may be able to talk to each other, but how would a food bank or the jail system or another social service agency be able to talk into these agencies? There is this disconnect. And so we invested really quite early in saying we have to build a solution that all can have interoperability, transparency in the system. What is happening inside the community can actually be shared with a clinical provider if the patient or the client requests that. So you have supports to support actually whole person care. And so I think that this has been a very big advancement that we've been able to push in our community. And then when COVID actually arrived on the scene, we were able to use this model in our community to really look at how do we push out telehealth so that our community health workforce can still support our community and really push towards value. So I think that what you've connected on is something that I'm actually passionate about, which is that connecting of those two, but having a communication platform that allows that connection to happen so value can be realized.
This is amazing. I think in the clinical side, everybody has their EMR, and there's care coordinators, they have their care coordination systems. The EMRs don't talk to each other, the care coordination systems don't talk to each other. So that's the clinical provider side. Community agency side, they have their own systems. Sometimes they're even working on spreadsheets, or they've developed their own access databases, and they're not connected. And then the patients, right? So if we talk about a Medicaid population, we know the vast majority now have cell phones. They have at least a cell phone, if not a smartphone. And so there's an opportunity here, not just on the clinical side where we see people moving to the cloud, the hospitals and the clinics to coordinate things, but also bringing the community into that and then bringing the patients into that. Does that make sense?
Absolutely. And I think having that connection point of the opportunity for the community-based agencies, the community partnering agencies that are really important to the care delivery, to that whole person care. I mean, it is one thing for me to go to a physician, so you, Dr. Nace, and you get to give me a prescription and you to tell me what my care, what I need to do for me to improve my health. And then I walk out of your office and I go out into the community to my life, and I don't have the social supports that I need and actually to carry out your plan, your treatment plan for me. And so then I come back to your office in 2 months and I still haven't improved, you know, my whatever condition I may have, which could be multiple conditions. But what we can do is with this connected resource, we're able to activate not only what's happening inside the clinical space, where I walk out, I can connect into a community health worker, a prematura, a care coordinator, and then that data can be shared back. So you know that actually I'm getting the supports I need so I can carry out not only the treatment plan as the patient, but I can also get the supports I need as the client in the community. And I think that that is what has been missing. When we look at all the past work of HMOs, you know, the health managed organizations back in the 80s, the 90s, I think the failure in the system to date has been the lack of connecting the community and the community resources into the clinical space. And so in my mind, this gets us to a step. If we can get the data all connected in, then we can get the contracts to align with the data. Then you also have contracts that can not only just be on the medical and clinical side, but we can also contract for social services. And to me, that actually makes a much more valuable and viable system.
You know, I think the work that you do at Elevate Health, which is an accountable community of health, I mean, that's why those CMS and others have focused on this idea of not just an accountable care organization, the ACO, as the value-based care contract, but the accountable community of health is a key one. And I'm so proud of what Elevate's doing. And I mean, you're a top performer as an ACH. So you're really setting the future for how this might look. And that brings up a good question is, what is the future? What will Medicaid look like in 2014?
So, you know, I think actually, I think the patient, the client is going to have far more say in how their data is used and how they interact in the system. I think that we at Elevate Health are very proud that, you know, we early on started a community advisory council, which is made up of patients and clients from all over the community that are either have experienced homelessness or have utilized Medicaid or been without work or have had kids in jail or incarcerated, have been in and out of the health system, have multiple health conditions, and they serve as a committee of my board. And sometimes the conversations aren't easy to hear because sometimes they feel that we're not listening. And what has come from that has been this open transparency of listen and engage and make solutions that work. And with that, we were able to actually address the issues. And I think we're going to see more and more of that going forward. I think there's also a need and a wish for our Medicaid patients to not only have better health, better care, better value, and a voice in their care, but there's also an interest in workforce development. And that is an area that we are very passionate about, is how do we actually engage individuals that have been in this system, that have had experiences of health issues or poor outcomes, to engage as workforce, community health workers, as I mentioned, navigators. That is the best workforce you can get, because you can reach, the outreach is far deeper than someone that comes in with multiple degrees that doesn't know how to communicate or talk to different populations. Data helps inform that as well. And this is where we're opening the door to say, this is a community asset. This is a community-driven value ecosystem. And this is not to be driven by one or two institutions. This is to be actually driven by the community and owned by the community. And so I think it really comes down to this more of a community health network or a community care network. That is, we are accountable to the community. So I'm not accountable to a commercial shareholder. I'm really accountable to my community, which is all the shareholders in my community. And I think that is the level setting. And that to me is the future. And it does allow us to support not only our providers, but it supports the community first and foremost.
You know, that it's such a great vision, and it really, the pandemic, COVID pandemic has brought, I think, to many of us the enlightenment that the public health system has been relatively ignored compared to the medical system, and they need to come together to really serve the community. Let's check in with our audience and see what their recent trends they're seeing with respect to their Medicaid population. So if each of you could go into the chat box, we'll present that and just select one or more of the following. Are the kind of trends you're seeing a rise in Medicaid enrollment due to a spike in unemployment during the COVID pandemic? Is it increasing adoption of value-based care models, such as an accountable care model or an accountable community of health? More need of technology solutions. Maybe that's a need that you have to manage these populations. The shift of primary care away from shift to primary care to hospitals, or is it investments being made in person-centered holistic care? So please put those in. You know, Alicia, the thing that dawns on me is there's a lot of trends kind of coming together here that we need to manage, aren't there?
I do, and you know, it's interesting because I talk to my team, and you know, I just have the most incredible team that I get to work with at Elevate Health, and community members that I get to work with, and partners, both clinical and social service partners. And we were talking just at a meeting on Friday that our work is it's not just has breadth, it has depth, right? There is so much to do. And in order for us to actually address the need and to really look at the entire whole person care delivery, we have to really have our hands and our eyes on everything, because we think that we may look at one component of the care delivery. If we don't also address others, you're going to basically push down on something, but something else will rise, and it may not have a good impact. And so, you know, our team and is always looking at how do you actually ensure that the full care continuum is looked at and addressed. And that's a big heavy lift.
No, that makes sense. Well, given that heavy lift, let's check in with our audience and see what they're dealing with. Interesting. Well, certainly the rise in Medicaid enrollment seems to be an issue. What do you think about what you see here, Alicia?
And I think this is absolutely spot on. We've been really watching the rise in our region, and you know, I've been looking at it across the state and then across the nation. We have had a huge rise in unemployment in Pierce County, which is the county that I live in. That's where Elevate Health is centered, and it is causing major impacts. It is causing, we're seeing increased trauma in the region. We're increased crime rates in the region, increased need for additional services. Our team that runs the Care Continuum Network, you know, we have clinicians and support, our support agencies that are doing the care coordination are seeing spikes in need. And I think this goes to the point where our One Pierce Fund has really helped support, working with the county government, really supporting our small businesses to ensure that they can stay in business. So not only our small behavioral health providers and SUD providers, substance use providers, but our small businesses. How do we sustain their doors to stay open so we can keep people employed? And I think that, you know, there's a ripple effect to this whole thing. And I think we can't just look in the healthcare space. We have to look in the entire space and say, what is the economics of this entire thing? Because once the economics becomes unstable, our entire health becomes unstable as a population. And Medicaid is the basis of it all. So, you know, that goes back to the third one, which is the technology. This is why technology is so important, and my team and my board and my community has heard it over and over again. I really feel we have to build a solution that is interoperable, that is agnostic to other solutions, that we can connect in together so we can actually see the data in real time, not only as for the clinical providers, but for the social service providers, but also for our politicians, so they can make good decisions for not only policy changes, but where they can direct tax dollars to support infrastructure. And that the technology solution can do it when you can stack the data appropriately.
Well, that makes sense. Well, let's get deeply into this and talk about solutions and, you know, what can be done. You know, I think there are 4 factors that come up frequently in the conversations that we have with Medicaid agencies. This issue of data that you brought up. How do you integrate data, help manage your contracts, both in the healthcare system, managed Medicaid, and then in the public health system, and then bring them together? How do you really create collaborative care, right? Bringing the traditional clinical together with the community agencies. How do you utilize those community resources to really advance health equity, which we know, particularly in the pandemic, that there are populations that do not get equal care? And then lastly, you know, how do we really optimize the efficiency? Because, you know, we're all struggling with costs in addition to managing all these pockets of data, and how do we get this together, and how do we engage all members, clinicians, care managers, community agencies, public health, and the patient? How do we get them to all collaborate? So let's get into these 4 focus areas. First, you've brought up data, and you've seen these agencies, the Medicaid management organizations, the healthcare systems, and then you as an accountable community health looking at the public health system. What do people think need to deal with in this issue around data?
Well, you know, I think that it goes all to the siloed approach, right? So you have a managed care organization would have their clinical claims data. They would have certain components of social data that they would have through their care coordination that they do, but they really don't have all the data stacked. And you would have the same with health systems. You would have certain silos of data. Same as with public health or community needs assessment from a health system that's a nonprofit health system. You have all these different elements of data that's not actually put together. And what we've really been trying to accomplish as a shared community asset is bringing those disparate sources together and having data use agreements and a governance structure that has a safety component in it that allows us to bring all of that together for really, you know, what it says here is, you know, to manage how we actually deliver not only the care for the clinical side, but also how do we manage the care continuum or the care traffic control for care coordination outside the clinic walls. And then how do we actually have analytics for public health, for population health? And I like to say, we sit at the intersection of public health and population health for community health. And then really, how do we have the shared savings components? And in my mind, a accountable community of health or accountable health community or a community health collaborative or whatever you want to call us is really that community table where everyone can see value for themselves. So a health system CEO, a MCO CEO, a for-profit commercial health plan CEO, a community member, or a social service agency can basically look at it and say, how do we can use this to for utilization patterns inside our agency so we can support the population we serve. And to me, that's going to help us manage the contracts that we're in and the cost drivers. And if we do this right, we can also have shared savings come back into the community to reinvest back into the community. And that is a big driver for me and the managed care organizations in our state know, I really feel that when we do interventions that are health improvements and we do it as a community, And the benefit goes back to the managed care organizations. They should share some of those savings back to the community so we can reinvest and we can actually improve the health of our population long term. And I think it's a win-win. It's a win for them, it's a win for us as a community. And this data helps inform that.
You know, I think about all these disconnected agencies, and then I also think about what we've been trying to do with Elevate, and the vision that you've had is kind of like what Amazon did. Like, you know, it connected all the different retail organizations in the world, right? Not just in the US, with all the consumers, and then also with the supply chains and the wholesale, not just retail front store, and then the manufacturer. I mean, they're all connected to make things more efficient. And they all have a private and secure access. So just like all those agencies never thought they could collaborate, the same thing could be true in public health and in care. And I think the capabilities there, Amazon and others have demonstrated that. How do you bring in data from all these different sources and then actually activate the data for people to be successful in these contracts? Let's go into the second focus area of collaborative care. You know, we've always talked about care management, right? What's collaborative care management?
You know, and I think that this is where we really are focused on whole person care. And I think that is, it's patient-centered, it's family-centered, it is really understanding and listening to the need, and it's bringing the system to the patient or to the client. And it's ensuring that we use data to help inform decision-making. And in my team, you know, I watch in awe with my team. I think that the work that they have done and the work they've done actually with Innovator as our technology partner and platform, and with our community and clinical partners, is the protocols that have been built out for not only Pathways, which is an evidence-based national model for mid to rising care coordination, but also with, we're a health homes lead for healthcare authority for the state, which is more high-risk population. And then for our community health action teams, which is really bridging that multi-specialty practice team with a community-based care coordination for addressing kind of the higher needs of a population to improve the outlying needs. When I watch that, it means that we are coming together, listening to the community, listening to the patient, listening to the client, and we're building the care and care coordination around that. And it means that it's not just clinical focus. So it means how do you support, like you said earlier, the GEL population, recidivism rates. A lot of the populations we're seeing that's in the jail or have, you know, they're also inside the ER or being readmitted to the health system. How do you actually ensure that you're building a system that supports that whole? And we have members on our team that are working with our county on a project for the jails. And we have the same members working on projects for hospital readmissions to ensure that we have continuity in the way we actually build out our workflows. And we're building those workflows on the technology platform, so there's synergy and connectivity. And I think that to me is the key component of a true care management program and model that is collaborative in nature. Our region has also adopted the collaborative care model for clinical care, and we are the first in the state and actually first in the nation for the pediatric collaborative care model through the UW, University of Washington. Very proud of that. And that also sits on the patient-centered workflow. And to me, when we start doing these types of changes in the system, it brings value to a different level. And that means the contracts need to change to reinforce that, and shared savings needs to come back to a community. So you reinvest more in innovations in the future.
No, I really enjoyed hearing your conversation, how you bring this all together, and the community collaborative with the clinical is something that you're actually achieving, which is fabulous. There really is an incredible opportunity here, isn't there, around whole person care, but also in the continuum of life.
Absolutely. And this framework, I'm just absolutely, I love, and my community has heard it over and over again. I think that Colorado did a great job with this opportunity framework. Early on, I said, we really have to adopt this. It's really looking at how do we support the ecosystem from the beginning to the end and ensure that we're not looking at something in just a silo and we're not doing one-offs. We're actually looking at the education system. We're looking at our environmental scans. So when we look at the pie graph, healthcare costs and healthcare costs are huge, but the healthcare is 10% or 20%, whatever model you're looking at. But environmental factors, biological factors, our education, all of that is the bigger part of what makes our health and what makes our outcomes either improve or decline. And when we look at a model like this, we can look at data to help inform. We can talk to our policymakers and advocate for changes in the system. We can redirect dollars to ensure that we're having the right care at the right time, have the right contracts in place to provide the right care at the right time. It's our responsibility with the funds that are provided in a Medicaid space to support the population the right way and with the right framework. And so I think that this allows us a really solid basic framework to work from. I get really excited about this one.
Yeah, no. It's funny. I was along with my good friend Paul Grundy, who's here working with us now. We started this patient-centered medical home movement because I'm an old family doc, and I watched this. No one in the audience knows Marcus Welby when I was growing up. He was a doc in a small town who got to know all the community, right? He was a member of the business association. He saw patients and thought about this whole continuous working with the family from day one, right? And thinking about the needs in the community. That's not achievable today. That world doesn't exist anymore. And so I think there's a model here that can bring us away from this idea of bankrupting states, but bringing people together and then reinvesting the dollars to get continuous quality improvement. I think one other thing that's come up because of the pandemic is this issue of, can we actually address this issue of health equity?
And I think so. And I think this is part of this care traffic control or care continuum network that we have really we're building out, and we've built many elements of it so far. And I think it is really ensuring that the providers, the clinical providers, are aware of the importance and have knowledge of what's happening in the community space. And I think that this understanding of what is happening with the social determinants of health all the time and the connecting of their community resources. And this is one of the important components that I had talked to at when we had talked to Innovator early on, is really having that closed loop referral people talk about, and ensuring that when something is happening in the community, that the providers get word of it, so it closes that loop. And I think as I've shared this story before, but as a mom of a young child with special health care needs and not only physical, but we had a lot of learning issues. I had some issues of getting and navigating the system, and I would have to repeat my story over and over again to the clinical providers, and then I wasn't getting the care I needed in the community space. This would have been so incredible as things were happening in the community space with some of his learning components. It could have been fed back into the clinical space. And that closed loop really just helps in frustrations and sometimes in depression, in just life flow of a population. And when that happens, the equitable, not only access to care, but equitable care delivery, quality of improvements, the entire space changes because the conversation changes. You don't have to repeat yourself over and over, and the patient or the client feels like the provider isn't listening. And that right there is a basis of belonging or equity, as others may call it. And this is why technology also can serve as that connector point. It's important. It's a very important resource.
Yeah, I'm looking at this picture of a cell phone. You know, we all have one of these. I have mine right here. It's on mute so that we don't get disturbed, but I'll take it back off. You know, but everyone has these, and we know the vast majority of Medicaid populations are connected too. So we can connect the clinical services, the community services, the patients, and then get all that data together in one place, just the way we all know and rely on Google to have all this data from different knowledge sources to search for things, or Netflix to find all the different entertainment, whether we want to buy it or it's free, and be able to connect and have us watch when we want. We can do that in healthcare. The capability is here to move things to the cloud and start to coordinate. So this is so exciting. You know, lastly, I think, you know, I brought up states going bankrupt because of Medicaid, and yet the, you know, health is starting to improve because of Medicaid expansion. What's the opportunity here to really improve the efficiency by connecting and engaging people here, Alicia?
You know, I believe, and I think we've heard this from our community as we have our conversations in our community, the more that we engage community members, the more in true authentic conversations, and the more that they have data that can help them support their lives, and the more that they're connected and they feel like that the connection is not just a one-off conversation and then nothing happens, that the loop hasn't closed. What happens is the compliance seems to increase. They stay engaged, they stay active with us. And we saw this in some numbers that Jody, my COO, and our data analyst, they provided to our board this last month. We saw this engagement from our care coordinators that are in the community, that know the community, that know how to engage with the community, and know it's really this efficiency components that are put in place, right? So we know what needs to happen. We have the science of improvement activated, and then we do the outreach the effective way, and we keep engaging. We do the follow through. What we saw was this incredible reduction in cost, and it was over $6 million over 244 patients, and it was a very small patient population, a very large reduction in spend. And we thought, gosh, if you could actually escalate that to this larger population that we're trying to serve, and you do put these practice efficiencies in place, and you do these engagement strategies the right way, you follow up, and you ensure that you're doing that rapid cycle improvement when you have breaks in the system, and you're using the data to inform improvements, and you fix protocols that could be broken, then you could actually decrease the spend more or improve the quality of the patient outputs better. What I'm just blown away by that. But what I want to see long term is that when we see that funding mechanism like that, not only do the states benefit in their budget shortfalls, but we would like to see reinvestments in those savings back into the community. And so to me, that is the win here is the patient. Number one, they win because we have the follow through, because we have the data, we have the mechanisms to do the follow through, and we're optimizing, but we're also saving dollars in the system to be reinvested elsewhere. And that's huge.
Yeah, it is huge. And, you know, it's I hope more states, more Medicaid agencies, more healthcare systems start to understand that we can really bring costs down and improve health and improve care. And now that we have this tremendous technology capability, and the pandemic has accelerated this concept of digital transformation, finally moving to the cloud. This is really great. Well, let's check in with our audience. Let's see what challenges that they currently face in managing their Medicaid populations. Please go into the chat box and fill out, again, multiple choice like last time. What challenges are you currently facing in managing your Medicaid population? Is it having a unified and comprehensive patient view across all these different sources? Is it managing the financial drivers? Is it solving for this issue of, well, we know these social determinants of health, economic, environmental are an impactful, but how do we bring them into a care plan as a clinical group? Is it engaging with patients in real time? You know, now that we all have these smartphones and can create that capability, or is it managing network leakage? Again, if you have a contract and you're trying to manage costs, you want to make sure you have these closed loop referrals to agencies that you trust and are high performers, whether they're community agencies or clinical agencies. So let's go ahead and take this poll. Alicia, you brought up this issue of the pathways model. I'd like to hear more about that. What is this pathways model?
So the pathways model is an evidence-based model for mid to rising risk population. It was originally came from the Alaska. Dr. Mark and Dr. Sarah Redding worked up in Alaska. The population really looked at how do you actually connect the social determinants of health with clinical care, supporting the clinical care delivery model, and you utilize community health workforce to really support the population towards their health improvement journey. And it's using standardized pathways. There's 20 standardized pathways, and they really have a really structured steps in order to have an outcome. And so it allows the standardized process for outcomes-based social determinants of health closure. And it is a fantastic model. And what they saw was when you actually hire people from the community that are of the community, you increase access, you increase connectivity, you increase outcomes, and you increase health of the population. And so part of our waiver project with our 1115 waiver, we adopted the pathways model here in our region in order to really support that clinical and community-based care coordination, really supporting that, bringing in that social determinants of health into the clinical space. And what we see is this incredible opportunity for not only prior to COVID for us to connect in for the community space into the clinical components, but it allowed us to, during the COVID time, really support our public health department and our clinical providers and the population at large with the social determinants of health for isolation and quarantine. We were able to get services to the population. We were able to use these standardized pathways to support that population in real time. Also the beauty is we had this pathways model on our technology platform, so we were able to go virtual really quickly because the technology with Innovacer was able to help us virtually support our community health workforce. And with that, it has allowed us to not only have, it's not one-off care coordination where everyone's doing their own thing and you think that you're tracking social determinants of health. It is actually, we're following a standard protocol. And from that, we've been able to build our COVID protocols that are very standardized. And the tracking of the data is far more rigorous that way. So it's been a really great journey, and we have jumped in really early on to support that mid to rising risk of our population, so we can really help move people away from that high risk, high cost care. I think that is the key component, is really to get as many people as we can early on into some type of support, so we don't have more higher cost, high care needs long term.
No, I think that's a great vision. It sounds like you're taking some evidence-based workflows and protocols and really putting them into action. That's so exciting. You know, I'll go back to my Amazon model. You know, if I think about yesterday, I ordered something, it's arriving today. You know, I got to go in and browse to a couple stores, retail places, pick one. I could see user responses, and it arrives today. There's a lot of different organizations that have to be coordinated. It's not just one. And it's all done on the cloud. So why can't we do that in healthcare? Make that efficiency. Let's take a look at our audience and see what they thought their challenges were. Wow, well, there was one clear issue here. Alicia, what do you think?
I think the financial performance drivers, it's huge. And I think that this is what the key component of why having the data together and understanding the data and having transparency in data is vital. Early on, we at our agency, Elevate Health, was key on strategic improvement, ensuring that we looked at the triple aim. So we are a member of the Institute for Healthcare Improvements Leadership Alliance, and we believe that the triple aim, we've actually adopted the quadruple aim, which is looking at not only the better care, better value, and better experience of care, but we are also about the equity component of the care delivery system. And without all of those pieces together, you cannot actually change the finances of this model. And I think with what we're putting together is allows us to really adjust the way we pay for care and the way we deliver on those financial outcomes. And so when I've talked to you, Dr. Nace, about this a lot, is I really do believe payment models that have some shared risk and shared savings is going to help improve not only how we pay for Medicaid and how we care for our Medicaid population, but it also allows transparency in the system, and it allows us to reinvest in innovations and care coordination that will long-term drive down the cost of the system, because we're able to make data to inform how we do this. Right now, we're working sometimes in a silo, and so we think we're throwing money and we're throwing interventions at things that we don't have. We're working in silos of data. As you said with Amazon, when you pull people together or you pull the components together, you're able to see that bigger picture. We need to do that in healthcare.
Yeah, well, speaking of that bigger picture, let's take a look at one way that I know that you've been thinking about it. What are all these different components in this bigger picture that need to be thought of?
I think it's that universal record. It's really looking at that whole person. It's using data to inform it. I think that what we're seeing is once we see different pieces of the data, we realize, oh, we need some additional data to be pulled in order for us to actually understand even more. And so I think that this is what has been great for us, is the partnership with Innovator has really helped Elevate Health understand even what we need because of the work that has been done with ACOs across the country. And we are a little different because we're bringing in other community-based agencies that are not maybe part of an ACO. When we're saying we want to make sure that we're looking at public health and population health for community health, it is more than just, the clinical components. And I think that that's why that collaboration and communication is so important, because you're dealing also with local government, you're dealing with local food banks and local transportation and local educational systems. And all of those components are going to help us actually understand, and all of these together, it will help us make decisions to drive down the cost of the system and reinvest in long-term improvements. It really actually goes to, the whole workforce. It goes to the ecosystem of a community. Where do we invest in, safety, education, workforce of a community? This allows us to have a platform inform that long-term vision. So we can care for the patient now or the client now while we're looking towards the future. And that's key.
No, that makes a lot of sense. And I think all of these things, again, we've seen in other industries. I'm looking at this last thing, customer relationship management. I'm in San Francisco looking at the Salesforce Tower. Salesforce has done a lot of this in retail. How do you manage, a consumer or a patient and really think about improving their experience, right? So that they can access, but that's a key, is how do you nudge, right, the patients into the appropriate places? Because the services are there, they're just disconnected.
And I think that having this platform and having the ability for the patient or the client to have access to their information in real time, to have input into it, to help co-design improvements, I think it's absolutely key. And the ability for technology to listen and then to make changes to reflect the needs of the consumer is going to be the future of where we go. And that's going to be also, that information is going to inform how we deliver care, how we deliver support services, the entire picture, and really how the contracting happens in the future.
No, that makes sense. And I really want to thank our audience for coming and listening to sort of some of the great advances that you've made at Elevate Health as an accountable community of health. And just a little quick picture is, this is the piece. I know you've said very nice complimentary things about Innovator, but this is the piece we've brought to the table. We're trying to provide the solutions that we see in other industries, like the ones I mentioned, Google, Netflix, Amazon, like bring that to healthcare, not just healthcare, but public health as well. And I think this is the thing that this pandemic, it's been a silver lining, is the recognition that public health is so critical. The community health, the health of patients, where they live, in their home. And there's just so much more I'm sure that you and I could speak about. I know you've done a lot around like health homes and gosh, I think about that. I learned more when I went into a patient's home in an EMS flow than I ever did sitting in a clinic, looking in an EMR. So the kudos to you for this. Do you have any final thoughts about how the future of Medicaid will change for people and how quick that might come about?
Well, I think it's, it's quickly evolving. I think COVID has taken us a decade ahead because we've had to evolve a lot, and I like to say that Elevate Health is really that community activation platform. We really want to be an asset for the community, and we're also, really wanting to be that, to listen. But I think that this COVID time has really moved forward, and we can't just go back. We can't go backward, and we have to use what we've heard and what we see and keep moving forward to support our community. And I think that that's where we're going to have open access, improved quality, whole person care. And I think we have to use platforms like this. We have to use community platforms that are not just siloed off where a few people are calling, and making all the decisions. It has to be far more of an integrated approach to care delivery, or we will not get where we need to go.
No, that makes a lot of sense. And I love the collaboration between us, helping you with the power of a health cloud that we can provide to help your accountable community of health be so successful.
Great.
With that, I just want to thank you, Alicia. This has been a tremendous and insightful webinar. Thank you so much for your participation.
Thank you for the opportunity. It's always a pleasure to speak with you and to be a part of this. So thank you, and it's a lot of work ahead. Enjoy it.
And thanks for the audience. You all are in the trenches doing the work. So look forward to working with you in the future as well, as we all work together in a collaborative way to solve these problems for Medicaid patients. We will send out a copy of this PowerPoint for those who are interested. And once again, thanks everybody for the participation. With that, this ends the webinar. Thanks, Alicia. Thanks, everybody.
Thank you very much. Thanks.
All right. Everybody have a great day.